So I'm hoping what you can see is a slide that just says menopause for the non-menopausal and just introduces myself. I work for DCHS in the Sexual Health Services Monday to Wednesday, and then I work as a private menopause specialist and psychosexual therapist on Thursday and Friday. So why do we need to talk about the menopause? Just in a way of introducing it, well, the average life expectancy now is 83, so many can expect to live a third. Many women can expect to live a third of their life after the menopause, and studies have showed that about 3/4 of women around that time are having symptoms, a quarter are having severe symptoms, and a third of those are having long-term symptoms which might last more than 7 years. And studies have also shown that many women think that they should put up with the symptoms, that they fear not being taken seriously or fear being judged for needing help. And also women can be unaware of some symptoms, because I mean, although in recent years people feel maybe more free. Many people maybe feel more free to talk about the menopause. Up till then, it has been a bit of a taboo subject, and it's only recently been added to the school PHSE curriculum. And it is mentioned in the GP curriculum. It's a minor mention. Obviously, the GP curriculum will be massive because they have to know something about a lot of stuff. The hashtag Make Menopause Matter, you might want to have a look at. It's run by a nurse called Diane Danzibring, who is very passionate about highlighting the need for more education about the menopause. So this again is more evidence. This is so there's been quite a number of surveys done, particularly in the last 10 years. This is one done about 8 years ago by the Faculty of Occupational Medicine. It basically highlighted that menopause symptoms can pose major and embarrassing problems for some women, particularly at work, making them feel less confident and at odds with their desired professional image. And the study also picked up that majority of women didn't really want to disclose their menopause related health problems to line managers, particularly young male line managers, because they perceived that they might not get a positive, a supportive response. However, other studies have shown that actually young male line managers are desperate to be able to support, really want to be able to support their workforce. Again, the study picked up that in the workplace, the management of gender-specific health issues other than pregnancy was rarely discussed. And it also picked up that it was a very busy time in women's lives, the sort of ages between 50 to 64, that a quarter of those women, as well as working, had informal caring responsibilities as well. It talked about the sandwich generation, caught between women at that age, caught between having children or grandchildren to look after, and pet parents and in-laws, so a lot of other responsibilities going on as well as working, and it's worth highlighting that 70% of women now work. There's 3.5 million roughly UK women who are 50 plus, and so 36% of the workforce are women over 50, and there's actually about I can't remember the figure. It's nearly 1 million women certainly in healthcare. The figure is much higher. Women that are working over the age of 50. And this particular study showed that 56% of women in the study felt that their work and home life was affected by their menopausal symptoms, and 42% perceived their job performance was affected as well. So in order to decide what to talk about today, Sarah and Alison sent out a survey to staff, asking them what they'd always wondered about the menopause, or what you'd like to ask a colleague, friend, or relative. So there was actually those surveys have produced a wealth of qualitative information that I've tried to summarize. I know the slide looks a bit busy, but I'll just sort of focus on the highlighted bits. So things that people wanted to know about were demographic things like what age it starts. Is it just older women? How do you know when you start the menopause, and how long does it last? People wanted to know about symptoms, what the symptoms were like, how to control symptoms, and how to cope with changes. And personal resources and support. People wanted to know about, how they could, how people going through the menopause could make it as positive experience as possible. And for people not going through it, anything that they could do as a colleague, relative, or friend to help make it better. And people wanted to know about why there's this perceived lack of support. Why are so many women still suffering with symptoms in this day and age? Why is there not much support, educating, and understanding in primary care? So so those are the things I'm going to focus on in my talk. And the other thing that was picked up, that so this a chart basically summarised what I've just mentioned, but also it also picked out that one of the other questions people wanted to know was, do men suffer a menopause? So I've included a slide about that as well. So just as a proviso, so the information that I'm going to give today is as accurate as possible, but it is only general advice, and not a substitute for seeing your own GP or healthcare practitioner. So I'm just going to start then with symptoms. Hang on, I'm just trying to make my slide look a bit bigger to me because I'm struggling to read it because I'm got to that certain age, and so the symptoms that women can get around the menopause are to do with the fact that estrogen receptors are no longer getting stimulated as much. So women have estrogen receptors all through their body, which is why I've put a picture of a female body there. And women are born with so many eggs in each ovary, and they by the time of puberty, at least half of those have just sort of withered away, reabsorbed into the body. And then through the reproductive age, when women are producing eggs every month, one is released every month, but there are the others just sort of get reabsorbed into the body, and this process goes on until eventually the eggs in the ovaries get used up, and it's the cells around the eggs that produce estrogen. And so the cells around the eggs stop producing as much estrogen, and then gradually, so the estrogen receptors in the body don't get stimulated as much. So symptoms affecting the brain. I know hot flushes and night sweats, affect the whole body, but it's to do with the temperature regulation zone in the brain. Sleeplessness, reduced concentration, headaches, psychological symptoms as well, such as low mood, anxiety, irritability, low energy, and reduced sexual desire. And then in the uterus, so because there's less estrogen being produced, the lining of the womb isn't stimulated by the estrogen, and so periods eventually become less frequent and eventually stop. Then there's lots of estrogen receptors in the bladder, the urinary tract. So a lot of women can get symptoms of frequency of passing urine, urgency, recurrent urine infections. There's lots of estrogen receptors around the vulva and vagina, so women can get dryness, which can lead to painful penetration and reduced sexual arousal and orgasm sensation. Skin can be affected. The skin can become drier, more itchy. Joints, cartilage, and muscles have got estrogen receptors as well, so women can get a lot more aches and pains and stiffness. And then there's lots of other weird symptoms that people can get, a sort of feeling of pressure or tightness in the head or body, parts of the body even feeling numb or tingling, or sort of sensation changes. Okay, so the thing about symptoms is that it's not only the physical experience of a symptom, so symptoms always engender an emotion as well, and thoughts around the symptoms, so that is added to the experience. And then there are also other long-term effects of the reduction in estrogen in women's bodies that you can't necessarily see. So before the menopause, women have a lower risk of cardiovascular disease, but start to catch men up around the time of the menopause and afterwards. And that again is an effect of the reduced estrogen levels on the formation of plaques in the arteries. And the other thing is that after the menopause, the bones start to lose mineral, and so bone density reduces, and that means that the risk of fracture increases. So the most common areas where this can happen is the wrist, the spine, and the hip. So in terms of age, the so-called natural menopause, the ovaries stop releasing eggs round about sort of age 45 to 55. So the menopause itself means period stopping, but obviously women can start to get symptoms way before that, what we call the perimenopause. So although the periods might stop at age 45 to 55, sort of for the preceding 5 to 10 years, they might start to get the symptoms that we've been speaking about. And then 1 in 100 women get what's called a premature menopause, which is where their periods stop before the age of 40. And this can be caused by women that have to have chemotherapy, radiotherapy, or surgery, but it can also be spontaneous. It might be due to an inherited predisposition or an autoimmune condition, or just unknown. We just don't know why. So do men have a menopause? Well, they don't technically have a menopause, because that means periods stop, but some men do get hypoandrogenism, which is where their bodies stop producing as much testosterone, which is the more dominant male hormone. So this affects about 3% of men in their 60s and about 5% of men in their 70s. So it is more common with age. And as you can see from the list of symptoms on the right-hand side there, the symptoms that they can experience are very similar to what women around the time of the menopause can experience. So I'm afraid this looks like a really busy slide, but I wanted to put it in because this is the qualitative information that we've got from the survey that Sarah and Alison sent out. So this asked, well, what has been unexpected about your menopause experience? So this was a question asked of women going through the menopause. That presumably work for the trusts that they cover. So I haven't got time to go through everything, but I'll just pick out a few things. So I've sort of grouped them into different areas. So physical symptoms, particularly cognitive symptoms. So And then just pick out a few things. So one person said it was unexpected. It started in their 30s. It was a big shock how the symptoms affected their day-to-day life. And cognitive symptoms were mentioned a lot of times, such as forgetting, brain fog, fatigue, lack of concentration, word finding difficulties. Other physical symptoms included the amount of different symptoms and pain, hair breaking and feeling thinner. People talked about hot flushes, but I had no idea the intensity of the feeling and the frequency. And then somebody else mentioned about weight gain and the struggle to lose it. And then another group of experiences I've grouped under psychological symptoms. So one person mentioned the impact it had on their mental health with anxiety and paranoia, the crushing crisis in confidence and memory problems, and another how it messed with my energy levels and mood. And then another area I've grouped into knowledge and support, either the lack of feeling lack of knowledge and support, or having the benefit of knowledge and support. So a few people mentioned the lack of support, and then a few people mentioned how that they didn't feel alone when they realized that their experience was very, very similar to others. And it was reassuring that to learn that some of the odd symptoms that we talked about were actually part of the menopause. That felt liberating. This is another question that was asked. So it was asked of what menopausal women wanted their colleagues to know about the menopause transition. And again, I've grouped it into physical symptoms, psychological symptoms, and advice. So overlap with the previous slide. So things that were mentioned under physical symptoms were, I mean, there's some wonderful quotes like no longer feeling themselves, feeling like simple things are a struggle. It's like somebody swapped my head with somebody else's in the night. Difficulty concentrating, and as before, cognitive symptoms such as brain fog, mood swings. So, and somebody pointed out that they noticed that in the office they tended to be more quiet when they were experiencing more mood swings and brain fog. And then psychological symptoms, a few people wanted to sort of share how much of a struggle this time can be, and how much of a sort of whole body and mind experience. And somebody's pointed out that there are physical symptoms, but unspoken are the psychological symptoms that we've talked about, such as sort of low mood, anxiety, irritability. And then the other area, the sort of other area people wanted their colleagues to know was to give advice, really. So that it's not something that just happens to older women. It may, symptoms may start earlier, that it is an important subject not to be ignored, that it's widespread and affects us all differently, and sort of stating how the benefit of being equipped and knowing the signs and symptoms before you reach that age, but also supportive in that you're not, to hang on in there, and that you're not alone. You're not the only one going through these symptoms, and no, you're not going mad. Okay, so I think we've sort of picked up that the change, which it's also known as, often happens at a very busy time of life. But I don't want to sort of paint a picture that it's all doom and gloom, because there are potentially positive positive things that can come out of having a menopause. So for women who have very heavy or painful periods, such as endometriosis or fibroids, then the menopause, not having periods anymore, can be a real blessing. And also, if women are really fearful of wanting to avoid a pregnancy, then there's no more pregnancy worries. And premenstrual syndrome, a lot of women can find this quite debilitating. And I notice you've had quite a few talks about that recently, which is fantastic. So again, going through the menopause can be liberating for women who have really struggled with PMS or premenstrual dysphoric disorder. And one of the other things that we do get throughout, as we get older, is life experience and wisdom. And that in our culture maybe is something that we've forgotten about, really. That in our culture, the sort of media-driven focus on youth and beauty, whereas in other maybe more indigenous cultures, older people are more respected maybe because of their wisdom and life experience. So this again is more a slide, again more information from the questionnaire. So respondents were asked what were their positive outcomes and experience and advice about the menopause. Well, it's true to say that not everybody who answered had anything positive to say, but those that did, then one of the themes was about talking and sharing. So as you can see, there's lots of rich information there about how people had found that talking about the menopause, discussing it, so breaking that taboo, getting the support of other women, sharing experiences, finding out that they're not alone, was really, it was a positive outcome for them. And we'll come back to this thing about the issue with getting healthcare professionals to listen and support. So these were other themes that came out of this question. So there was a theme about personal development, so finding out about various treatments, knowing myself a little better, and being able to be open about this stage of life and accept this period, about embracing the changes. HRT, so results from HRT, so that was a positive experience for one person. Self-help, so there was quite a few people found that positive experiences for them were things like keeping focus on a daily routine, diet and exercise, herbal remedies, and finding out about those. And then the other theme was about workplace support. So there was advice about what one respondent felt that their employer was generally interested in the well-being of its female staff's welfare when it comes to the menopause, and advice about talking to your manager, work colleagues and friends, because you're not on your own. Okay, so I'm just going to just whiz through a little bit about self-help and stuff, and management options for the menopause. So self-help stuff includes things like fans, sprays, cool pillows. You can get even like pillowcases and mattress covers that have got a cooling effect. Sleep hygiene, so having a good sleep routine and making sure that because it's a busy time of life, have it, carving out relaxation, me time. So we talked a little bit about natural therapies. A lot of women found that finding out about natural therapies was very helpful for them. So in terms of research base, there's actually 3 natural therapies that have got some evidence base behind them, and those are red clover, soy supplements and black cohosh. It's worth just mentioning that you should always look out for this logo, the THR logo, traditional herbal remedies logo, which is some validation of strength and quality, because there's loads of herbal remedies out there. So the ones which have got that logo, at least you know that there's some validation of strength and quality. Although the thing about natural therapies is that they're not regulated in the same way as HRT and other medications. So just moving on to HRT. So the active ingredient in HRT is estrogen, and it can be taken orally or transdermally as a patch, a gel, or now even a spray. So women who don't have a uterus, who've had a hysterectomy, can just take estrogen, which is great. But women who still got their uterus have to take some progestogen as well. And this is either taken cyclically, so they take the estrogen all the time and then the progestogen for 2 weeks out of every 4. Or if they're at least a year after the last period, they can take it continuously, and that way they don't have to have a period back. So lots of benefits from HRT, short-term ones such as hot flushes, sweats, improving low mood and anxiety, muscle joint pains and sexual problems. And long-term effects, it can reduce the bladder and vaginal symptoms. It stops bone loss, so it reduces fracture risk, and it keeps muscles stronger. And there's more evidence accumulating that certainly HRT taken around the time of the natural menopause might even reduce cardiovascular disease. It actually does reduce the risk of developing diabetes, and combined HRT, there's a slight reduction in the risk of bowel cancer. So, and this slide, I think this is probably the main reason why, well, in terms sort of going back to people wanted to know about why maybe is there this perceived lack of support from healthcare professionals. So this slide is supposed to look a bit like a balancing scale. So in the 1990s, you know, HRT was like the new panacea. Then in 2002, we had a couple of studies in the noughties, the Million Women study and the Women's Health Initiative study, which are still in the textbooks, that the current cohort of healthcare professionals have grown up with. So, and those cause a lot of scare about the risks of HRT. Since then, now in this in the sort of last 10 years, we've had the NICE guidelines on the management of the menopause, and many more studies which have put into perspective the risks of HRT. So hopefully there's, you know, now the evidence is much more balanced about the pros and cons of HRT. But the trouble is that the people that trained and qualified in the noughties, you know, and as I say, the textbooks still have the original data in, which has now been sort of reanalyzed and criticized and reviewed. So you know, that's one of the difficulties, I would say. And also, I think the way that general practice, this is my personal view, is the way general practice is organised, in that you get very short amount of time with your GP, and it's very difficult in that small amount of time to sort of talk through all the issues. I would say it's impossible, really. And of course, GPs have so many things that they have to be to know about, and they're very they are very overwhelmed. Anyway, I'll leave it at that for now. So just sort of summarising the risks of HRT. So if you take oral HRT, there's a slight increased risk of blood clots on the leg or lungs, but transdermal HRT doesn't increase the risk. And again, with stroke, there's a slight increased risk of stroke on HRT, but again, transdermal HRT doesn't increase the risk. And there's a small increased risk of gallbladder problems when women take hormones. It's the same, there's an increased risk of gallbladder problems on the contraceptive pill as well, and also when women have a pregnancy. So most people worry about breast cancer, it's not an uncommon condition. So this infographic shows that actually, so over 5 years, in women aged 50 to 59, over 5 years, 26 per thousand women aged 50 to 59 will get breast cancer, even if they're not on HRT. If they're overweight, if their body mass index is 30 plus, then there's an extra 24 cases, almost double the number. If women take combined HRT for 5 years, then there's an extra 14 cases over 5 years. That's a couple of cases per thousand per year. There's also an increased risk of breast cancer if women drink more than 2 units of alcohol a day. The risk with estrogen only HRT is much smaller. And then you have to sort of put into perspective risk reducing factors as well. So taking at least 2.5 hours of moderate exercise a week actually reduces your risk of getting breast cancer. Other things to do with breast cancer and HRT. So the risk is duration dependent. So sort of this is the risk for 5 years use. If you take HRT for longer, then the risk is probably a bit higher, but the risk reduces in the decade after stopping HRT. And women who take HRT under age 50 don't need to worry. The slight increased risk of breast cancer only starts after women start taking HRT over the age of 50. The other thing to say about breast cancer in women who take HRT, the incidence is slightly increased, but the mortality rate is not affected at all. And there's certain progestogens that might have a lower risk, particularly digesterone and micronized progesterone. So a lot of women get vaginal and bladder symptoms. They might not have taken HRT, might have not really had many symptoms, but then found that maybe sort of 5 or 10 years after the menopause, they're getting a lot of bladder and vaginal discomfort. And they might not link it to the menopause. It's what we call genitourinary syndrome of the menopause, but it is eminently treatable with lubricants, moisturizers, vaginal estrogen, which is very, very safe. Even women who've had breast cancer can take vaginal estrogen. And there's a couple of other treatments as well, which I haven't got time to go into, but I'll put on my handout. For women, so there's very few absolute contraindications to HRT, such as current breast cancer, but there are certain non-hormonal medications that can be helpful for some women. So there's something called Clonidine, which has been around for donkey's yonks, SSRI and SNRI antidepressants, and there's also some complementary alternative therapies that have been shown to help, such as acupuncture and hypnotherapy. This is another bit of research that's been done recently. So, and we mentioned that particularly hot flushes and sweats it's not just the actual physical sensation of the hot flush and sweat, it's our emotional response to the symptom and our cognitive response to the symptom. So for example, somebody, if you're feeling hot and sweaty, maybe you're sat at work, you're in a meeting, physical symptoms, hot, sweaty, palpitations. So a sort of negative thought might be, oh, everybody's looking at me, I can't cope with this, and then that might lead to a feeling of anxiety, embarrassed, feeling out of control, and that might lead to avoiding going into meetings or leaving the room. So CBT for flushes, sweats and sleep problems. There's now self-help fact sheets available, books that can. So there's a self-help book, and there's also a manual for people who want to run groups on cognitive behavioral therapy for sweats and sleep problems. So these are possibly the more balanced thoughts that CBT can help people to learn. So giving people information about what's happening in their body, training people about negative thinking patterns and how to counteract them. So instead of thinking that everybody's looking at me, I can't cope, sort of trying to replace that with thoughts such as, well, this, I know this is going to pass soon, let's just deal with this flush for now. And something called paced breathing, which you probably know as like belly breathing, tummy breathing, can really reduce the autonomic arousal, and so that can be helpful for people to learn to do through a hot flush. Okay, so workplace factors that can affect symptoms include the culture, the environment, you know, if it's hot, humid, ventilation, confined. So stress, so workload, deadlines, formal meetings, having to learn something new, presentations, lack of access to toilet facilities, cold drinking water, lack of regular breaks and quiet rest areas. So synthetic workwear and uniforms, and the type of work as well. So shift work and physical work can affect symptoms. But there's lots of things employers can do to help. So you know, working on the culture change, so breaking the taboo, sort of training, including menopause, having policies, sickness absence policies, menopause policies, occupational health and staff wellbeing services can help, maybe with advice about workload, task switching, support with stress, and support with mental health symptoms as well as the physical symptoms. If possible, temporary changes to working practices, so avoiding, allowing breaks where needed, flexible hours, if possible, time off to attend medical appointments to help sort out, help with symptom management, and then common sense environmental changes like fans, well-equipped toilets, cold drinking water, non-synthetic uniforms, lighter uniforms, quiet workplace rest areas, and a less confined office environment. Okay, so I sort of whisked through it really. You know, I could spend all day talking about all of these things, but I want to leave a bit of time for questions. So we've been through some facts and figures about the menopause. We've talked a bit about symptoms and the management options that are available. We've talked about the real benefit that a lot of women in the survey really appreciated in terms of you know, finding that talking to colleagues and having groups where they could talk to others, they found really helpful. So if I had any advice for colleagues who in supporting somebody going through the menopause, I'd just say, well, listening skills, and just allowing your colleague to talk and share what's going on for them. And we've talked a bit about the reasons for the perceived lack of support. Okay, so